Yeah, so a normal ultrasound, transvaginal ultrasound, will tell us about endometriosis, but it can miss the subclinical or grade 1 stages where the ovarian cyst has not yet formed. But a very trained ultrasonographer will catch that the uterus is less mobile. It might be because of the adhesion, the uterus is not very mobile. Many of the times the uterus is retroverted, very immobile, and the patient is feeling pain during the passage of the probe as more, I mean, a little more than the general population. So these are the things which increases the index of suspicion from a doctor's perspective that this patient might have endometriosis, and the typical history of triple will also point to examination and the uterosacral ligaments which are deep down connecting the vagina back to the sacrum. They generally have the deposits of endometriosis, and the patients feel pain at the time of the vaginal examination because of that. So these are the indicators. They're all indirect indicators. The direct indicator is just the laparoscopy, but I don't think laparoscopy should be. We should always keep a high threshold for any surgery because every surgery can have complications. So the reason that we are doing a surgery should be substantive enough for us to actually do a surgery because there's anesthesia involved. At the end of the day, it's a surgery, and there is a possibility of a complication. So every surgery should only be done when enough indication is there to do the surgery. Um, but before the surgery, we generally have the pelvic examination or the ultrasound. Another thing which generally people do is MRI, but it's not it is not going to add. So if a very trained doctor is doing an ultrasonography, it is going to give enough information that MRI would not add much to that information.